Okay, guys, let's talk about amenorrhea. Questions that confuse you on big exams, the misunderstood questions. Okay, so take papers and pens and let's go. Preparing for your big board exams about amenorrhea. So amenorrhea, absence of the menstruation, is not a disease itself, but rather a sign, actually symptom and of an underlying condition. Is broadly classified into, broadly of course, into primary amenorrhea, that is absence of menarche by age 15, or by age 13 in the absence of secondary sexual characteristics. And secondary amenorrhea, cessation of previously regular menses for 3 months, previously irregular menses for 6 months. So understanding its causing and implications is crucial in clinical practice. It's a 1 point. Next point, my beloveds, don't forget it. Might be very obvious, but you have to answer like this. Primarily caused of secondary amenorrhea. Of course, is a pregnancy. Pregnancy is the most common cause of secondary amenorrhea. While seeing obvious, its frequency means it must be the first consideration in any woman of reproductive age presenting with missed periods. Overlooking this can have a significant consequences. So it's not just for exam I'm talking about. So always ask about this question. Do you have problems with men's cycles, with periods? Without, I don't know what. Without confusion. About erectile dysfunction, we ask guys. And men's periods, we ask ladies, no, of course. Okay, so what is clinical importance of that? Always perform sensitive urine or serum beta-human chorionic gonadotropin, beta-HCG. Test to rule out pregnancy before proceeding with extensive hormonal or imaging investigations. So this avoids unnecessary test exposure or radiation, and delays in appropriate prenatal care or management of ectopic pregnancy. Next point, about FHA. It's a functional hypothalamic amenorrhea. So, functional hypothalamic amenorrhea, FHA, represents a survival mechanism. So, the brain, specifically the hypothalamus, can suppress the reproductive axis in response to significant physiological or even psychological stress, excessive exercise or low energy availability, often due to restrictive eating or eating disorders. It's essentially the body deciding conditions aren't optimal for pregnancy. So we have to understand that the pregnancy and the men's cycles are something luxurious for lady, for female body. So that's why be very careful about this point. So if ladies got normal men's cycle, means she can be pregnant. But it's a luxurious condition. So the lady's body have to be in the perfect condition. This involves, so actually we have to understand that these situations of functional hypothalamic amenorrhea involves reduced pulsatile secretion of GnRH, gonadotropin releasing hormone. So why it's so important? We understand now that functional hypothalamic amenorrhea is a diagnosis of exclusion. Okay? So you will be asked about that, of course. It's common in athletes, dancers, and individuals with eating disorders, sometimes part of so-called the female athlete triad of relative energy deficiency in sport, so REDS, REDS. Okay? Don't dance. Next, recognizing this FHA, functional hypothalamic amenorrhea, is vital because the primary treatment involves addressing stressor, nutritional rehabilitation, reducing abnormal exercise intensity, managing, if it's possible, God bless, physiological, psychological stress, rather than just hormone replacement from the beginning. Though that may be needed for bone health. No, it depends, of course. It signifies a systemic energy imbalance. Remember that, my beloveds. Not just for exam, I all told about that. Huh? Next, about previous lecture, it was, several times we used to talk about that, about polycystic ovary syndrome. Of course, polycystic ovary syndrome is the most common endocrine cause of secondary oligorrhea, oligomenorrhea and amenorrhea, today's topic. So polycystic is a complex heterogeneous disorder characterized by hyperandrogenism, not clinical or biochemical, ovulatory dysfunction leading to amenorrhea and irregular cycles, or irregular cycles, periods, and or polycystic ovarian morphology on ultrasound. Remember, refreshing our memories, Rotterdam criteria, so previous lecture concerning polycystic ovary syndrome. So its exact cause is multifactorial, involving genetic and environmental factors leading to insulin resistance and hormonal imbalance. Actually, hormonal imbalances, plural. Why it's so important? So diagnosing this polycystic ovarian disorder. So diagnosing this polycystic ovary syndrome is a critical, not just for addressing amenorrhea and infertility, of course it's of paramount importance, but also because these patients are at a significantly increased risk for all metabolic chain, type 2 diabetes, hypertension, cardiovascular disease, you name it, so rheumatoid arthritis, gout, liver disease, and kidney problems, intestine problems, neurological status problems, endometrial hyperplasia, cancer due to chronic unopposed estrogen from anovulation, autoimmune disorders, and so on and so on. So management requires a multidisciplinary approach in your brain, focusing on lifestyle changes. Lifestyle changes, I repeat, it's of paramount importance. Physical activity, avoiding of fast sugars, drinking water. Managing metabolism comorbidities and cycle regulation, sometimes with combined oral contraceptives or progestins. And addressing hirsutism of infertility, if desired. I suppose it's desired. Next, about hyperprolactinemia. So elevated prolactin, that is hyperprolactinemia, directly, these pronunciation problems, those directly inhibits the reproductive axis. So prolactin, primarily known as that's why it's the name, prolactin, primarily known for only lactation, prolactin, directly suppresses gonadotropin releasing hormone secretion from, of course, hypothalamus. It can also impair the gonadotropin follicle stimulating hormone, FSH, and luteinizing hormone, LH, action at the ovarian level. This elegantly demonstrates the intricate hormonal feedback loops governing reproduction. Why it's so important? Measuring serum prolactin is a standard part of the amenorrhea workup. Elevated levels warrant investigation for causes like pituitary adenomas. Prolactinomas, for example, require brain MRI. Hypothyroidism, thyroid releasing hormone stimulates prolactin. Certain medication, for example, antipsychotics, metoclopramide, chest wall stimulation, or significant stress. Treatment targets the underlying cause, for example, dopamine agonist like bromocriptine or cabergoline for prolactinomas. About POI, premature ovarian insufficiency, is not just early menopause. Not just this. So, premature ovarian insufficiency is defined as a loss of ovarian function before age 40, characterized by amenorrhea, low estrogen levels, and elevated gonadotropins, FSH and LH. So unlike menopause, where ovarian follicles depletion is complete, some women with premature ovarian insufficiency may retain intermittent ovarian function and even conceive spontaneously. Spontaneously, though rarely, of course, spontaneously conceive, something interesting. So the cause is often idiopathic, but can be genetic, for example, Turner syndrome, mosaicism, fragile X permutation. It's not obligatory to remember. But another cause is autoimmune or iatrogenic, our problems, chemotherapy, radiation. So why it's so important? Premature ovarian insufficiency has profound implications for fertility, psychological well-being, and long-term health due to prolonged estrogen deficiency, so increased risk of osteoporosis and cardiovascular disease, and so on, all chain of metabolic syndrome. Diagnosis requires high clinical suspicions with elevated FSH levels, not typically more than 25, 40, up to 40, international units per liter on two occasions. So next, management involves hormone replacement therapy, controversial, but anyway, changing of lifestyle is of paramount importance. But anyway, hormone replacement therapy until the average age of menopause is a 51, not 41, 51, for symptom control and prevention of long-term sequelae. Counseling regarding fertility options, so for example, oocyte donation, and screening for associated conditions, for example, autoimmune disorders. So remember, you will ask about all that, my beloveds. If not in Armenia, in India. If not in India, United States. If not in the United States, United Kingdom. Or I don't know where, in China. God bless all these countries. Russia, like my Armenian. Anyway, so structural abnormalities can prevent menstrual flow despite normal hormonal cycles. Structural abnormalities. Yes, of course. Amenorrhea can occur, even it's a rare phenomenon, but it happened. So amenorrhea can occur even if the hypothalamic or pituitary ovarian axis is functioning perfectly. Congenital anomalies like imperforate hymen or transverse vaginal septum mechanically block menstrual outflow, often presenting as a primary amenorrhea with cyclic pelvic pain. Mullerian agenesis, Mayer-Rokitansky-Kastler-Hauser, MRKH syndrome involves congenital absence of the uterus and upper vagina, Rokitansky. Acquired obstruction, like Asherman syndrome, intrauterine adhesions, scarring, usually after uterine surgery, like the dilation and curettage. Presents endometrial proliferation or blocks outflow, causing secondary amenorrhea. So why it's so important? A thorough history, cyclic pain, madam, previous uterine procedures, and physical examinations, including pelvic pain, are crucial. Pelvic ultrasound is often the first-line imaging modality. HCG is a hysterosalpingography, HCG, or hysteroscopy may be needed to diagnose Asherman syndrome. Management depends on the specific anomaly, ranging from simple hemenotomy to complex vaginal reconstriction or hysteroscopic adhesiolysis. Next, low estrogen, sorry. Amenorrhea due to low estrogen has significant implications for bone health. So, about estrogen. Estrogen plays a critical role in maintaining bone density by inhibiting osteoclast activity, that is bone resorption, and promoting osteoblast activity. This is a bone formation. Conditions causing chronic hypoestrogenic amenorrhea, like functional hypothalamic amenorrhea, premature ovarian insufficiency above mentioned, or untreated hyperprolactinemia, lead to accelerated bone loss. So why it's so important? Patients with prolonged hypoestrogenic amenorrhea, we talk about more than 6 months. Typically more than 6. We will be asked how long is it? Typically more than 6 months are at increased risk for osteopenia and osteoporosis, potentially leading to fragility, how fragile we are, to fragility fractures later in life. So bone mineral density, BMD, and BMD assessment using so-called dual energy X-ray absorptiometry, DEXA, 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 it's acronym, should be considered in these patients, if you get this DEXA, of course. Management of the underlying cause of amenorrhea is paramount. If estrogen levels cannot be restored, for example in premature ovarian insufficiency or persistent functional hypothalamic amenorrhea, despite lifestyle changes, 3-time underlying, despite lifestyle changes, hormone replacement therapy is often indicated to protect bone health. Adequate calcium and vitamin D intakes are also essential, but with physical activity. Without physical activity, it serves nothing, it's useless. About progesterone, so progesterone challenge test actually, yes? So this test can help localize the problem. Progesterone challenge test. This simple pharmacological test helps us differentiate causes of amenorrhea. Administering a progesterone like medroxyprogesterone acetate, if I remember correctly, my memory doesn't fail me, medroxyprogesterone acetate for 5-10 days mimics the luteal phase of the menstrual cycle. Mimics, of course. If withdrawal bleeding occurs after stopping the progesterone, it indicates that the patient has adequate endogenous estrogen to proliferate the endometrium, obviously, and responsive, very good name, responsive endometrium, and the patient, and the patent open. Outflow tract. What's so important? A positive test, so withdrawal bleeding, suggests the primary issue is likely anovulate. Is likely anovulation. So withdrawal bleeding, positive test, suggests the primary issue is likely anovulation. For example, polycystic ovarian syndrome, mild hypothalamic dysfunction. A negative test, no withdrawal bleeding, implies either low estrogen levels, hypothalamic pituitary failure or ovarian insufficiency, requiring, of course, follicle stimulating hormone, luteinizing hormone ratio, so measurement, or an outflow tract obstructive uterine anomaly, like Armen syndrome, so requiring imaging. We have to note that it has been declined somewhat with easier access to direct hormone assays and ultrasound, but it remains useful clinical tool, especially in resource-limited settings. Now about thyroid, my beloveds. Of course, thyroid dysfunction can directly cause amenorrhea, directly up to pronounce. Both hypothyroidism and, less commonly, of course, hyperthyroidism can disrupt menstrual regularity. In hypothyroidism, elevated thyroid-tropin-releasing hormone, TRH, can stimulate prolactin release, causing hyperprolactinemia-induced amenorrhea. Thyroid hormones also have direct effects on ovarian function and estrogen metabolism. So why it's so important, my beloveds? Taking thyroid-stimulating hormone, it's a fundamental part of the initial amenorrhea workup. Correcting the underlying thyroid disorder, for example, with levothyroxine for hypothyroidism or antithyroid drugs, radioiodine surgery for hyperthyroidism, often, very often, especially in hypothyroidism, restores normal menstrual function with lifestyle modifications, definitely, without needing further specific gynecological intervention for the amenorrhea itself. Now, amenorrhea, my beloveds, remember that It's not only for gynecologists, I repeat, it's not for only for your board exams. Doesn't matter what narrow specialty you will choose, for example, my cardiology, or doesn't matter what. So amenorrhea is often a so-called canary in a coal mine. So, okay, amenorrhea, I repeat, is often a canary in the coal mine for systemic health. So what does it mean, this canary in the coal mine, if you don't know this proverb, huh? The menstrual cycle is a sensitive parable, actually. The menstrual cycle is a sensitive indicator of a woman's overall health. That's why you have to ask this question for guys: erectile dysfunction, for ladies about periods. So absence of periods can be the first sign, very often, of significant underlying issues, ranging from systemic diseases, thyroid disorder, adrenal disorders, pituitary tumors, genetic conditions, Turner syndrome, for example, nutritional deficiency, excessive physical or physiological stress, no psychological, of course, not physiological, psychological stress, two structural problems. So amenorrhea should never be dismissed, especially if persistent. It warrants a thorough and systematic evaluation to identify the underlying cause. Addressing the root cause is essentially not only for restoring menstruation, of course, no, if desired, at the same time, but also for managing associated high health risk. So bone loss, I don't know what, all chain of metabolic syndrome, cardiovascular disease, high arterial hypertension, diabetes mellitus, and so on. Actually, psychological distress, and detecting potentially serious pathology early, as soon as quick as possible, as early as possible, as soon as possible. It emphasizes the interconnectedness of the endocrine, reproductive, and overall systemic health, of course. So, holistic approach. Understanding these points helps clinicians approach amenorrhea systematically, ensuring timely diagnosis, appropriate management, and comprehensive care for patients experiencing these significant symptoms, my beloveds. No, that's all concerning your misunderstood questions. I hope I clarified all these confused, misunderstood questions for your big exams. I hope it will be helpful not only for your big board exams, but in your future medical practice. God bless you. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as don't forget to follow and subscribe my Telegram private channel. How to find it? Tap in searching mode, Dr. Y, like question, Dr. Y, it's me. Dr. Y, W-H-Y, without question mark, of course. So, you tap in searching mode in Telegram, Dr. W-H-Y, you find this, you click start, and choose your plan. Stay blessed.